Hello, I'm Dr. Nicholas Tedesco DO, the Associate Program Director for Samaritan Health Services, Good Samaritan Regional Medical Center Orthopedic Residency Program. Today I'm going to be presenting on the topic of small round blue cell tumors and bone-forming tumors in the orthopedic oncology realm of our ongoing didactics. Again, these are designed to supplement our in-class formal learning. As usual, disclosures, I do own stock in RomTech, which is an orthopedic rehabilitation company, but they have nothing to do with this talk or any of my other talks. So we'll start off today with small round blue cell tumors. We chose to put this with the bone-forming tumors simply because these overlap quite a bit in terms of age brackets. So many of these tumors are going to be in children, adolescents, and young adults. First thing we start off with is rhabdomyosarcoma. So this is a malignancy of immature skeletal muscle, often found in kids under the age of 10. Staging will involve a CT scan of the chest without contrast, a bone marrow biopsy, and a bone scan or a PET scan, whole body. Imaging involves a nonspecific low signal on T1, bright signal on T2 with diffuse gadolinium uptake in variable regions on the MRI, with other darker regions corresponding to central hemorrhage or necrosis. These are all very nonspecific findings, and virtually any soft tissue sarcoma can create this. So here's just an example of a large rhabdomyosarcoma in the calf muscle. Again, low signal intensity on the far left on the T1, very bright on the T2 in the middle, and then bright intralesional gadolinium uptake with focal areas of contrast void in the center. On histology, rhabdomyosarcoma is a small round blue cell tumor, hence why we're talking about it under this category. It has a small amount of eosinophilic cytoplasm, which does help differentiate it from other small round blue cells that have virtually no cytoplasm. There may be cross striations seen in this, depending on if you get lucky where you biopsy, which will hint at the muscular origin of this tumor. You'll see dense hypercellular areas admixed with loose myxoid areas, so sort of almost a biphasic pattern of tumor. The key here is the staining markers on immunohistochemical staining, which is going to be desmin, myoglobin, myogenin, and myod1. You may see CD99 positivity, especially in alveolar rhabdomyosarcoma. However, oddly, these also stain positive for cytokeratin, which is typically an epithelial origin marker. Additionally, one of the most tested topics about this really is the characteristic translocation found in these. It's a translocation 213 or 113, resulting in the PAX3 FKHR or the PAX7 FKHR fusion genes, respectively. So here's an example of it, mostly blue, no real pink stuff here. You do see a little bit of that eosinophilic cytoplasm surrounding these cells, but very densely packed, very pycnotic and hyperchromatic, very ugly looking hypercellular tumor, a lot of pleomorphism. Treatment of rhabdomyosarcoma is surgical resection if possible, radiation if possible, and sometimes you can do one or the other. So if you have a massive intrapelvic one that's unresectable, you may get away with just radiation therapy alone. However, outcomes are definitely better when this can be surgically managed. The other thing that needs to be taken into consideration is the sensitivity of young growing children and their growth plates and things like that with radiation, which can significantly damage these. So you do have to have a multidisciplinary approach with these, a strong discussion with your radiation oncologist as to when and where this might be appropriate. However, one of the mainstays of this is always neoadjuvant and adjuvant chemotherapy for both systemic and local control. This is what differentiates this from almost any other soft tissue sarcoma. This is treated much in the way of pediatric bony sarcomas in terms of chemotherapy playing a major role, but these tend to be exquisitely sensitive. Next is Ewingsarcoma. This is a malignancy of neuroectoderm origin. Staging involves CT scan of the chest, abdomen, and pelvis without contrast, bone marrow biopsy, and bone scan or PET scan once again, so virtually identical to rhabdomyosarcoma. It is the second most common malignant bone tumor in children and adolescents after osteosarcoma. On x-rays, you'll see a lytic, permeative, or moth-eaten bone destruction, often metaphyseal or diaphyseal with lamellar periosteo reaction most commonly. The other name of this is onion skinning. You can see a Codman's triangle, you can see sunburst, so this doesn't necessarily have any defining characteristic features on X-ray. Likewise, this crosses with eosinophilic granuloma and osteosarcoma in terms of its appearance. On MRI, however, you tend to have a large circumferential soft tissue extension, whereas osteosarcoma tends to be eccentric. So the soft tissue mass extension in osteosarcoma tends to preferentially go in one direction outside of the bone, whereas this tends to be much more centripetal, growing circumferentially around the outside of the bone. So here's an example of a young child in the midshaft of the humerus. You see this permeative, sort of moth-eaten, wide zone of transition. Can't really tell where the abnormal bone stops and starts. You see that onion skinning periosteal reaction. And then on the axial MRI, you see this large, nearly circumferential soft tissue mass extending all the way around the bulk of the humerus. So on MRI, it looks much more aggressive than it would otherwise appear on standard radiographs. On histology, this is going to be sheets of monotonous small round blue cells. There will be almost no cytoplasm, rare mitoses, and large necrotic areas can be seen. Additionally, you can see pseudo-rosettes scattered throughout the tumor as well. This is going to be CD99 positive, MYC2 positive, O13 positive, which is a downstream product of MYC2, PAS positive because of glycogen and the small amount of cytoplasm that there is, and reticulin negative. Reticulin negative is what helps differentiate this from a lymphoma. It's going to be S100 positive because of its neuroectoderm origin, Lu7, synaptophysin, neuron-specific enolase, and vimentin all positive. As we just talked about, you contrast with lymphoma by the reticulin, and lymphoma will also be PAS negative. You can contrast this with neuroblastoma, where neuroblastoma is vimentin negative, which is a marker of mesenchymal tissue origin. You can contrast this with embryonal rhabdomyosarcoma, in that desmin, MyoD1, and myoglobin will be positive for that. The other big thing with this is the translocation. 85% of all cases have a translocation 11 to 22, which is the EWS FLY1 gene. You can also have a translocation 21-22 in about 5 to 10% of cases. That's the EWS ERG gene fusion. And then you can have about 5% of these cases that are actually translocation negative. So that's where, again, all these other immunohistochemical staining patterns can help nail down the diagnosis. So here is an image of that. Again, small round blue cells, much less cytoplasm than what you saw in the rhabdomyosarcoma. But again, rather monotonous. All the cells look very similar. You don't really see mitotic figures or anything like that, but the hypercellularity gives this away as being malignant small round blue cell tumor. Treatment is going to be very similar to rhabdomyosarcoma. So surgery and radiation both can be used alone in certain situations, again in conjunction with a multidisciplinary approach to this disease. And then again, you want neoadjuvant and adjuvant chemotherapy for both systemic and local control. Primary lymphoma of bone is most commonly a non-Hodgkin's diffuse large B-cell variant. It ranges from an invisible margin on the x-rays to extensive mixed lytic and sclerotic changes, tends to be metaphyseal and diaphyseal. Usually it's going to be permeative, but again, we just mentioned that this can have a variable appearance on x-ray. Again, very similar to all the other small round blue cell tumors, it tends to have a large circumferential soft tissue mass on the advanced imaging that's not readily apparent on x-ray. So here we are again, we see the CT scan on the left. That's a longitudinal image of the patient's femur. They have a total knee replacement distally, which is giving the artifact down there, but you have this lytic, moth-eaten, destructive, permeative lesion extending throughout the diaphysis and distal metaphysis. On the axial imaging, you do see almost what appears to be a small hair-on-end appearance of periosteal reaction, but again, this very large, nearly circumferential soft tissue mass extension that's not otherwise apparent on the other images. Histology, surprise, surprise, sheets of small, round blue cells, very monotonous, and they can be different appearance, though, in this one because they may be in various stages of B-cell maturation. These tend to have this cleaved nuclei that are almost kidney bean shaped with infiltration of the marrow space, yet relative maintenance of bony architecture. You'll see smudged clusters of artifactually crushed cells that's nearly pathognomonic for lymphoma of bone. Basically what happens is when they put the small glass plate to cover the specimen on the larger glass plate to look at it under a microscope, these cells are so friable that many of them just get absolutely crushed and smudged. Reticulin positive, as we just talked about on the immunohistochemical staining, CD20 and 30 is going to be positive for B cell variants and CD3 for T cell variants. Leukocyte common antigen, CD45 will be common on all these, but it doesn't help differentiate it amongst the types of lymphoma because it's positive on all but red blood cells and plasma cells in the blood. Occasionally you can see CD45 negative and CD99 positive if it's B cell lymphoblastic lymphoma. So you have to use other B cell lineage stains or translocation analysis to differentiate this tumor from Ewingsarcoma. So again, the histology alone isn't enough. You need all of these other studies along with it to determine this diagnosis definitively. There's the histology. Sheets of small round blue cells all look similar, very scant cytoplasm if any. Looks remarkably similar to the rest of the pathology we've discussed so far. Treatment, this is very highly chemosensitive. So CHOP therapy is what we typically do for chemotherapy, and then R-CHOP is what we add for B cells because it's rituximab, which is an anti-CD20 monoclonal antibody. It is very radiation sensitive as well, and so typically we will radiate these areas. However, many studies are now showing that this could be problematic in weight-bearing bone because of the long-term effects of radiation, whether it's fibrosis, scarring, or osteonecrosis and fracture. So in many cases now we're using chemotherapy alone with or without surgical management for primary lymphoma of bone, depending on where it is, depending on a lot of other factors. So this is now a relatively controversial topic, and radiation now becomes a much larger discussion, again hinting at the multidisciplinary approach to management of these diseases. Corticosteroids do have a direct tumorolytic effect, so beware of tumor lysis syndrome in high-dose steroids during treatment for other disease processes. Where this happens most frequently is going to be spinal cord injuries. If someone has a lymphoma and they present to the emergency department with a spinal cord injury and they initiate the methylprednisolone protocol, you can push someone into frank renal failure, hyperkalemia, all kinds of metabolic abnormalities, and multi-organ failure by killing too much tumor all at once and spilling all of those cellular contents into the blood, overwhelming all of your organs. So you do need to be very careful with this and make sure you screen patients appropriately when considering steroids for pathology. Surgery is indicated for impending or pathologic fracture. Again, depending on the location, for instance, a clavicle may respond to chemotherapy alone with or without radiation and may not necessarily need surgery, whereas the distal femur is likely to need surgery. Neuroblastoma is another childhood small round blue cell tumor. It arises from neural crest cells and it's analogous to pheochromocytoma in adults. It's the most common childhood metastasis to bone. By definition, usually when it presents to orthopedics in the bone, it's AJCC stage 4. Treatment is going to be chemotherapy plus or minus surgery or radiation for impending pathologic fracture. Again, depending on the disease burden in the child, the plans and timing for chemotherapy, things like that. So again, multidisciplinary approach needs to have discussion amongst multiple specialists to figure out what's going to be the optimal management of these patients. However, if it happens to present to you first, typically what you're doing is working it up. So if you get a biopsy, it returns as neuroblastoma in the bone. Next thing is full staging, figure out where all it has gone, and that's going to involve this MIBG or methioto-benzoyl-guanyl scan, which is a norepinephrine analog that gets taken up by all of these cells. On histology, again, small round blue cells, you're more likely to see these Homer-Wright pseudo-rosette formations compared to some of these other small round blue cell tumors. It's going to be synaptophysin, CD56, and NB84 positive. So NB stands for neuroblastoma. Easy to pick that one out on a test. A Homer-Wright pseudorosette is the tumor cell around neuropil, which is a highly synaptic region of unmyelinated axons, glial cell processes, and dendrites. It's devoid of cell bodies. It's not to be confused with a true rosette, which is seen in ependymomas with cells around a primitive ventricle-like lumen. or a perivascular pseudorosette, which is tumor cells around a blood vessel, often seen in retinoblastoma. The final one not to confuse is the Flexner-Wintersteiner rosette, which is cells around a central lumen being created by the tumor cells, as seen in retinoblastoma. If you can differentiate these different rosettes, pseudo-rosettes, different names, things like that, under pathologic slides, you will be able to tell what histology is what. I don't know that you'll ever truly be tested on this, but this is the kind of thing where if you do know it, it will help give you some answers on the test as to what you're looking at. So here's an example of that. Small round blue cells, but then you see these pseudo-rosette formations in the middle where you have that neuropil in the center, so that proteinaceous, fibrous appearing stuff looks almost like mucin, but essentially when you really look at those closely, they're actually synaptic regions of neurocrest origin cells. Treatment, chemotherapy. Again, local radiation therapy if it's away from the growth plate or if prognosis is generally poor, and then surgery considered for impending or actual pathologic fractures. Another small round blue cell thing under histology, but not necessarily a tumor, is osteomyelitis. This is one of the great tumor mimickers. It looks, acts, presents, clinically behaves, radiographically appears like a tumor. These are infections of cortical and medullary bone, can be acute, subacute, or chronic based on time. Most commonly is going to be Staphylococcus species, Group A strep, pneumococcus, salmonella in asplenic patients, Kingella kingae, Haemophilus influenza, although this has become much less common over the years, and Pseudomonas or even fungal osteomyelitis. Presentation is typically pain, swelling, erythema, systemic symptoms such as fever, malaise. They may have a history of penetrating trauma. They may have had a recent infection. They may be immunosuppressed, but they may not have any of those things. Imaging on X-ray ranges from no changes at all in hyperacute within a few days to complete destructive lysis with extensive periosteal reaction after a few weeks to the long-term sequestrum and involucrum of dead bone, the sequestrum with abscess formation followed by the involucrum, which is the reactive bone surrounding it. This occurs a few months down the line. MRI will show low signal intensity on T1, high on T2 with extensive surrounding edema and periostitis, subperiosteal abscess. Gadolinium may show a large sequestrum, which is that dead bone, as a large contrast void, with surrounding involucrum, the reactive bone, having a high amount of gadolinium uptake because of the activity there. So here's an example of acute. You see this very subtle, almost onion skinning beginning of a periosteal reaction. You see a large lytic lesion with expansion of the bone. This could be Ewingsarcoma. This could be eosinophilic granuloma. This could be Telangiectatic Osteosarcoma. So this presents looking angry and aggressive like a tumor. You get an MRI, and here you see on the left is the T1 image with low signal intensity with intense surrounding edema, but otherwise preservation of the marrow. On the T2 in the middle, you do see a very bright signal on the fluid sequence with, again, all of that surrounding edema as well as the large amount of fluid centrally in that cavity. But then on the gadolinium image on the far right, you see no contrast taken up in that middle portion, which indicates that that's a large abscess or sequestrum. Here's the axial image of it, where again, this is a T2 where you have bright signal intensity in the fluid. You see the surrounding periostitis and elevation of the periosteum, which is that thin black line. Then you have that large sequestrum in the central portion of the bone, expansion of the bone and widened cortex reactively, and you even see a little bit of surrounding myositis from this. Chronic osteomyelitis is going to be more like this, more permeative, more moth-eaten appearance. Again, expansion of the bone, widening, destruction, areas of lysis, relatively aggressive looking, but the periosteal reaction now is a little bit more mature. It's thicker, it's more sclerotic, it's not as acute. When you get an MRI, you see preservation of bone marrow throughout on the T1, on that left side there, so you can see the high signal intensity indicative of marrow fat scattered throughout the lesion, whereas tumors will replace the marrow. So this is something that's infiltrating it. On the T2, you see it's very bright signal intensity from all the fluid. Again, you see that surrounding periostitis. You also see what's interesting on these images here, what looks like a large leg length discrepancy, and you can see the difference in the size of the femur both in girth and length comparatively side to side. Chronic osteomyelitis will increase blood flow to that bone, which actually results in overgrowth over time. So they will develop leg length discrepancies and significant anatomic asymmetries. Here's the axial images of chronic. So T1 on the left, T2 on the right. Again, a little bit of fluid intensity, again surrounding infiltrating edema into the muscle and subperiosteum, elevation of the periosteum. Otherwise, expansion of the bone and abnormal appearance of the bone. But again, a little bit of bright signal on that T1 indicative of preservation of marrow fat. On histology, you're going to see necrotic lamellar bone with scalloped edges and absence of stainable osteocytes and osteoblasts. You're going to see edema and granulocytic or polymorphonucleocytic infiltration of the surrounding tissues. That's the small round blue cells that get confused for other tumors. So you've got to look at those very carefully. So here's an image of that where you have the bone at the top. You have this dead sequestrum with very few cells in the middle, and then down below you have all those small round blue cells. Those are all the infiltrating PMNs that are reacting to this process. Unfortunately, this is kind of pixelated, but it's zoomed in to show you all of those neutrophils. So small round blue cells, but if you look closely even on this pixelated image, you can see that they have that PMN appearance, polymorphonucleocytes. So the nuclei are in multiple lobes that hint that these are all neutrophils and they're not clonal. They are all very different. Treatment is going to be CT-guided aspiration if suspected for frank pus or to obtain a culture. You want to do an irrigation and debridement if there is an abscess or a sequestrum, or if frank pus is aspirated from the bone, or if there's no clinical change after 2 to 3 days of antibiotics. You want culture-specific IV antibiotics for 6 to 8 weeks, although in children now this is becoming more controversial and there are many oral options available. Most common broad-spectrum antibiotics based on age, less than 2 months of age, you're going to use cefazolin, ceftriaxone, nafcillin, or an aminoglycoside. 2 months to 3 years, cefazolin or ceftriaxone, and greater than 3 years, cefazolin or nafcillin. If community MRSA suspected, clindamycin usually covers both MSSA and community-acquired MRSA, or Bactrim. Alternative treatments are going to include vancomycin or linezolid, but these tend to be very expensive and can be very toxic as well. That wraps up the small round blue cell tumors, and now we'll move on to the bone-forming tumors. We'll start here with malignant tumors and then move on to benign. The malignant bone-forming tumor is the malignant bone-forming granddaddy of them all, osteosarcoma or osteogenic sarcoma. General considerations for this is the most common bone sarcoma. It's classified as surface or intramedullary, and it often presents as Enneking or MSTS grade 2B or 3, which means high grade, extracompartmental, or metastatic. Peak incidence of diagnosis is the second decade associated with the adolescent growth spurt, with a second but much smaller peak over the age of 70. The young kids tend to get osteoblastic osteosarcoma. Older folks tend to get fibroblastic osteosarcoma. Younger folks tend to get what we classically picture in our heads with an osteosarcoma radiograph. Older folks tend to get a lytic process that makes it very confusing and difficult, and why it overlaps with metastatic disease in that age and can be confused for metastatic carcinoma. It can be associated with Li-Fraumeni syndrome, which is a P53 tumor suppressor gene mutation, retinoblastoma, which is an RB1 tumor suppressor gene mutation, or Rothman-Thompson syndrome, which is a RECQL4 gene mutation. Prognosis, best to worst, is low-grade intramedullary or parosteal, which is a low-grade extramedullary, periosteal, conventional intramedullary, telangiectatic, small cell, intracortical. This is so rare, we're not really sure where this falls, but prognosis is generally poor, followed by pagetic, followed by radiation-induced. So conventional osteosarcoma, which is the intramedullary form of this, 5-year survival rates is now about 70% with our current multimodal approach. About 80 to 85% of all osteosarcoma cases are conventional osteosarcoma. 10 to 20% have metastases at the initial presentation, typically to lung followed by bone. However, lymph node metastases can rarely occur. Location tends to be the metaphysis of long bones, most commonly around the knee, distal femur and proximal tibia. On imaging, you'll have a mixed lytic and blastic appearance of bone with destruction and formation of a Codman's triangle with spiculated or hair on end or sunburst pattern periosteal reaction. Up to 30% of the cases can be purely lytic, particularly adult, how we just mentioned, with no apparent bone matrix on the imaging. So these need very diligent workup and a high index of suspicion. You must get an MRI from the joint above to the joint below to rule out what's called a skip metastasis, which is a second focus of tumor within the same bone, completely separated from the main tumor mass. Clinically, these behave exactly like a wide metastasis. So even though it's relatively local regional, it's a sign of poor prognosis and a very aggressive tumor. So here's that classic appearance where you have mixed lytic and blastic with cloud-like bone formation indicative of osteoid. You have multiple Codman's triangles here at the level of periosteal reaction, as well as that hair on end periosteal reaction seen throughout the lesion on the borders. This is the MRI of the entire bone, again showing this is what a skip metastasis looks like. So there's the main tumor distally, nothing in between. All of a sudden a second focus of tumor more proximally. Histology of conventional osteosarcoma is going to be the classic lace-like osteoid formation by malignant mesenchymal spindle cells. So these are pleomorphic, ugly-looking, highly mitotic, hypercellular spindle cells within the background stroma. Most common subtypes of this, we alluded to earlier, chondroblastic, osteoblastic, and fibroblastic, with osteoblastic being most common in the young kids, fibroblastic in adults, and chondroblastic often confused for chondrosarcoma because the osteoid producing portion of this is usually very small, so the entire tumor is often needed in order to make this diagnosis. Here's an example of the osteoblastic. So this is that lace-like osteoid, so very thin, small, wispy pieces of bright pink osteoid being formed by this ugly background, highly pleomorphic, pycnotic, hyperchromatic tumor. You can also, if you look closely, see multiple mitotic figures. Just quickly, I can count about 7 on here in a few seconds. This is the chondroblastic form, so when you look at this, it looks more like chondrosarcoma, but the arrow here is showing us that small amount of osteoid production, and so this is where you really need to have a good pathologist, and you really need to scour this tumor to make sure you got the diagnosis right, because the treatment for chondrosarcoma is very different from osteosarcoma. This is the fibroblastic variant, so much more fibrous, spindly, not quite as pleomorphic as the osteoblastic. These cells are not as plump, but you still see this lace-like weaving osteoid throughout this, as well as the fibrous tissue in between. Treatment, no radiation except for palliation. So if someone is widely metastatic with a massive tumor somewhere that's causing significant symptoms, you can consider radiation there for symptom control. Otherwise, it does not play much of a role in this disease. You need a wide surgical resection of the primary tumors, but after neoadjuvant chemotherapy, then you're going to follow that up with adjuvant chemotherapy. Typically, it's going to be doxorubicin, cisplatin, and methotrexate, plus leucovorin rescue and ifosfamide, given in 3 to 4 drug combos for 6 to 9 months. Less than 90% necrosis, a high pre-treatment LDH, and a high alkaline phosphatase pre-treatment are all harbingers of a poor prognosis. Now we move on to telangiectatic osteosarcoma or osteogenic sarcoma. On imaging, this is going to be more of an eccentric osteolytic tumor, expanding or disrupting the bone. It's usually metaphyseal, again around the knee, and it will have a high signal intensity on T2, and usually you'll see the fluid levels that hint at it and why it crosses over with a lot of the findings of aneurysmal bone cyst. However, the difference between this and aneurysmal bone cyst radiographically on advanced imaging is that an aneurysmal bone cyst will peripherally enhance only after gadolinium, whereas this one will predominantly peripherally enhance, but there will be a small one or several foci of nodular enhancement scattered throughout it that indicate that there's a small amount of viable active tissue in there that's actually creating these large aneurysm cavities. Treatment is going to be the same as conventional osteosarcoma with neoadjuvant chemotherapy, followed by wide resection, followed by adjuvant chemotherapy. Here's an example in the calcaneus. You see that osteoid formation on the x-ray with the cloud-like formation. However, you also see the destruction of the bone. On the advanced CT, you see a subtle hair-on-end appearance of the bone, as well as osteoid throughout the lesion and areas of lysis. Then when you get your MRI, now you see multiple lobules, expansion, destruction of the bone with fluid levels throughout those lobules. On histology, you're going to see multiple blood-filled sinusoids with small amounts of osteoid and high-grade spindle cells within the cavity septae. This is what differentiates it from ABC, because ABCs can actually create osteoid as well, but they are very benign. Occasionally you'll see giant cells, much like in an ABC as well, so it's that high-grade spindle cell background that you have to look for that puts the nail in the coffin in this diagnosis. So here's an example. When you look at this from low power, all you see is tons of hemorrhage throughout this lesion and these huge empty white spaces. So this doesn't really give anything away yet, but now you know you're dealing with something hemorrhagic, something that creates large sinusoids. Now you zoom in and you see this lace-like osteoid production on the right, infiltration of the host bone, which is the large portions of osteoid on the left. And in the background, when you look at those cells, you see this high-grade, ugly spindle cell tumor with lots of pleomorphism, mitotic figures, pycnotic nuclei, hyperchromasia, all of that stuff. So this is a very malignant process. Here is another area, again, showing all the hemorrhage infiltrating this, but here you really get a sense of just how pleomorphic and ugly these background cells can be. So this looks almost like an undifferentiated pleomorphic sarcoma, but when you zoom out and you find that osteoid production, that now changes it, because you can get a UPS of bone as well. So what you have to find to nail this diagnosis is that malignant lace-like osteoid production somewhere in this disease. Periosteal Osteosarcoma is a very rare form of low-grade osteosarcoma, however, with the propensity to de-differentiate and become a high-grade osteosarcoma. It's most common in females, usually young adults, as opposed to children. 5-year overall survival is excellent at 92%. Location is typically the posterior distal femoral metaphysis in 75% of the cases, followed by proximal humerus, but again, this can actually occur anywhere. On x-ray, it is a very, very, very densely calcified, lobulated, heavily mineralized lesion stuck on the surface of a bone. So the density is similar to that of cortical bone throughout the lesion. It's most dense at the center, which is in contrast with heterotopic ossification, which is usually going to be most dense at the periphery. Differentiate from an osteochondroma with a CT or MRI that shows that there is no corticomedullary continuity with these. So here's an example coming off of the acromion of the scapula, where you see this heavily mineralized, dense, lobulated lesion. Tough to tell if this is in the soft tissues or truly stuck to bone, so here's where advanced imaging is going to help. Looks very mature, very chronic, does not look like a stereotypical osteosarcoma. When you get your advanced imaging, now you do see destruction of the bone associated with this large soft tissue extension of this very densely calcified mass, but no corticomedullary continuity with the host scapula. We just mentioned these have a propensity to de-differentiate. This usually happens with recurrence. So typically you recur when there's inadequate margins. So the name of the game with this disease, and you'll see down at the bottom of this slide, treatment is surgery, not chemotherapy as with other osteosarcomas, and you have to do a good surgery. If your margins come back positive, you have to go back in there and take more tissue. As long as they're negative, prognosis and local control tends to be excellent. If it does come back, that's when it tends to come back at a higher grade, and now you may need to consider chemotherapy and a much bigger surgery. On histology, this will be much more bland cells with regular and ordered dense trabeculae and interspersed fibrous stroma, very different from other osteosarcoma appearances. It's notoriously difficult to biopsy because often all you see is normal bone or that fibrous tissue, and so they think fibroosseous lesion of bone. So this really is a clinical diagnosis based on a combination of the presentation and the radiographic appearance. Treatment, as we just mentioned, wide surgical resection. Chemo is only indicated if it does become high grade. Periosteal Osteosarcoma is another surface lesion. This one again is now back to the younger folks, more adolescents and young adults as opposed to children. Location tends to be proximal tibia and distal femur, often the anterior surface of the distal femur rather than posterior as opposed to parosteal, and the tibial diaphysis. It's the most common diaphyseal osteosarcoma, but a rare overall osteosarcoma. This one will have the sunburst pattern, look much more characteristic for osteosarcoma. However, it only involves the surface, hence periosteal osteosarcoma. You'll often see saucerization, or basically a scooped out concavity of the lesion on the bone surface with minimal to no intramedullary involvement on the advanced imaging. So here's an example of that, where you have this saucerization of that anterior cortex where it almost looks like a divot was taken out, but you have that small amount of cloud-like osteoid, you have the hair-on-end appearance. On the CT scan, you can see this heavily involves the cortex, but there's no obvious involvement of the intramedullary space. Histology will show high-grade lobular cartilaginous lesion. So this is where it starts to get confusing. They'll give you these images, they'll show you the histology, which will be mostly cartilage, and you'll want to pick a chondrosarcoma. However, just like chondroblastic intramedullary osteosarcoma, look for that small amount of osteoid production. It's in there somewhere, and osteoid always trumps chondral formation. So if you see osteoid, it's an automatic osteosarcoma. If you see chondroid, it's not necessarily a chondrosarcoma. So you'll see a chondromyxoid stroma with this, occasional osteoid production. Unlike other osteosarcomas, this will be MDM2 and CDK4 negative, whereas most other osteosarcomas will be positive. So here's an example of that, where you have this myxoid, cartilaginous, basophilic, low-grade component at the top, but then at the bottom you start to get more cellular and you see that osteoid production. So when you see this combination of osteoid production and chondral matrix, you've got a periosteal osteosarcoma. Here's an example of just that chondral production, and again, this can be very confusing, especially if they give you this slide where you say, oh, this is a chondrosarcoma. However, if you look very closely in the upper left part of this, that weaving lace-like osteoid that actually blends in with the hyaline matrix of the chondroid portion of the lower right of this screen. So this is a really tough one to differentiate, but you got to look very closely. Likewise, at the top, you start to see more plump osteoblastic-like cells as opposed to the large clear cell chondroid cells within the hyaline matrix on the bottom right. So periosteal osteosarcoma can vary from low grade to intermediate grade to high grade. So low and intermediate grade lesions is surgery only. High grade lesions is going to be treated very similar to conventional, that now involves chemotherapy. Chemotherapy has been used for intermediate grade lesions, but many studies have now shown that it may not improve survival or change the treatment outcome. So that's why we're moving more towards surgery only for that. You want to get an MRI to make sure that there is indeed no true intramedullary involvement. If that's the case, a true hemicortical resection can be performed, where you only remove the diseased cortex and not the entire bone as you normally would with osteosarcoma. That wraps up the malignant bone-forming tumors, and now we'll move on to the benign bone-forming tumors. We'll begin bone forming with Pagets disease because this is loosely related to osteosarcoma, because this can actually degenerate into a very high grade, very difficult to treat, chemo-unresponsive osteosarcoma. This is a remodeling disease defined initially by osteoclastic resorption and then disordered bone formation. So there are three characteristic phases of Pagets disease. Stage 1 is the lytic phase, which is idiopathic osteoclastic bone resorption spontaneously for reasons we don't fully understand. Stage 2 is the mixed phase, where reactive osteoblastic new bone formation starts to occur in a haphazard fashion. So this is structurally weaker and more brittle bone than typical. And then stage 3 is the burnt out or sclerotic phase, which is where osteoclastic resorption finally abruptly ends, and osteoblasts create enlargement of bone with thickened cortices and sclerotic areas throughout the medullary space. There is an autosomal dominant inheritance pattern and other unknown genetic factors in play here. There's a chromosome 18 defect on rank on osteoclasts, leading to overreactive response to rank L on the osteoblasts. that have been identified. There's an SQ-STM1 gene mutation. That's the most common gene mutation in familial cases. And then an OPTN gene mutation on chromosome 10 that have been found in many of these familial cases as well. There's also unknown if this is a viral cause. There have been paramyxovirus inclusion bodies found in the cells on biopsy. So it's still very unclear what truly drives this disease. Labs will demonstrate a markedly increased alkaline phosphatase, high urinary and blood hydroxyproline, and N and C telopeptides, which are all markers of collagen turnover. However, they will tend to have a normal calcium, phosphorus, and parathyroid hormone, which hints that bone turnover is not being mediated by a normal physiologic response to one of these hormones or electrolytes. On imaging, again, you'll see coarsened trabeculae with mixed lytic and blastic regions. You'll see cortical thickening, bony expansion, bony irregularities, almost a late onset dysplasia, so to speak. You'll see on the bone scan it's extremely hot and can be multifocal, happening in multiple bones. However, it can be in different stages. So one bone can be in the lytic phase, one bone can be in the burnt out phase. It's all over the place. Any areas of photopenia within a hot lesion are concerning for malignant change, meaning bone scans look at osteoblastic activity, so when that stops and the bone is being eaten alive by something, that's where it will get cold. So histology will show profound osteoclastic resorption with enlarged osteoclast, woven bones with irregular thickened trabecular bone, and numerous cement lines, which are these curved blue lines that I'll show you in just a minute. Treatment here is bisphosphonates, basically to stabilize and prevent the bone resorption. Calcitonin can be administered. However, Forteo or teriparatide, which is a PTH analog, has been shown to increase the risk of osteosarcoma degeneration in these, so you do want to avoid that. So here's an example. So you have multiple bones involved, you have widening of the metaphysis and the metadiaphyseal bone with an irregular shape now to it, but it's all very mature, very sclerotic, but then these random regions of lysis surrounding this sclerosis. When you get a bone scan, you see multiple bones light up on this patient in the bottom right there. When you do a biopsy and look at it, here you can see that very, very thickened trabeculae, much more than any of the other bone-forming lesions that we've seen thus far. And you see these curved blue or purple lines running throughout this. These are the cement lines that they talk about, which are sort of harbingers of bone formation, followed by rest, followed by more bone formation. So this hints at the underlying diagnosis of Pagets. Likewise, you can see in the intertrabecular spaces, not a whole lot going on there. There's no high-grade lesion or tumor or anything that's driving the formation of this. Next is osteoid osteoma. 50% of these occur in the tibia and femur, usually diaphyseal and usually intracortical. In the spine, they're often in the posterior elements and on the concave side of a scoliosis. It's one of the most common causes of a painful scoliosis due to the muscle spasm in response to pain. So this is a correctable scoliosis with cure of the disease. Typically it occurs in young adults or later childhood. Males are more common than females. The tumor incites a local inflammatory response because it actually does elaborate PGE2, COX-1, and COX-2. So the pain tends to be worse at night, but it responds excellently to nonsteroidal anti-inflammatories and COX inhibitors. This lesion does not grow over time and has no propensity to metastasize. On imaging, you'll see a smooth fusiform or oval shape of the cortex with marked sclerosis and extensive periosteal reaction, but it will be mature as opposed to immature like you see with osteosarcoma. CT is the optimal imaging for this that will show a nidus less than 1.5 centimeters, although typically it's only a few millimeters. And you also want to be getting this to assess your cortical integrity. You're going to need fine 1 millimeter bone cuts, or else you may miss it if it's a 1 to 2 millimeter nidus. If you get an MRI, it will show such extensive surrounding edema, periostitis, myositis, that it will be confused for many other things, including stress fracture, osteomyelitis, or bone sarcoma. So MRI is generally not helpful for this disease. On histology, you'll see sharply demarcated, highly vascular stromal nidus encased by cortical bone with osteoblastic rimming around the osteoid, which is what hints at a benign process. All the malignant processes we've seen so far, there is no osteoblastic rimming around the osteoid, and I'll show you that in a minute. So here is an example of that image. So you see this fusiform enlargement of the posterior lateral cortex of the tibia in this patient. No obvious nidus within there, but when you get this fine cut CT scan, lo and behold, you have that cortical thickening, and right in the middle of it, you have this tiny, small, little punched out region that hints at osteoid osteoma. So here's the histology, and when you look at this superficially, this can look very aggressive and ugly. And so you have all of this osteoid production, which is the pink stuff running throughout it. However, when you look closely, you have the red eosinophilic cells, which are all rather plump, larger, rounder than a typical spindle cell, and they're surrounding all of this osteoid. They're not randomly found in the middle of the intertrabecular spaces and things like that. So that's what then gives away that this is benign osteoid production as opposed to malignant. Treatment of this is usually observation with NSAIDs if they can tolerate it. These will burn out eventually. However, it can take up to 6 or 7 years for that to happen. So you have to weigh, long-term NSAID use and side effects with, potential time for treatment and chronic pain. And there are some case reports of progression to possible osteoblastoma, although this is relatively controversial. So if you're going to intervene and you're going to treat and going to get rid of this, you can either do a resection with curettage and burring, especially if this is in the spine where you have neural elements nearby, or if this is really close to a neurovascular structure. But otherwise, as long as you're not within a centimeter of a critical neurovascular structure, radiofrequency or microwave ablation is the treatment of choice. So you'll send them to interventional radiology for that. They drill into the bone under CT guidance, stick the microwave or radiofrequency probe in there, and just burn it to smithereens. And usually that's curative. If not, and if it comes back, you just do it again. One thing to remember is if it is a large lesion, or if it is in an area of a weight-bearing bone where there's concern for stress riser, you may have to either bone graft it, or prophylactically fix it, or put them non-weight-bearing afterwards to allow that bone to recover and rebuild itself. Up next is osteoblastoma, which is the big brother to osteoid osteoma. It's most commonly, again, in the posterior elements of the spine, but that's the most common overall location. If this is found in the long bones, it tends to be intramedullary, not intracortical, unlike osteoid osteoma, and tends to be diaphyseal once again. Similar to osteoid osteoma in presentation, but no reliable response to NSAIDs. That being said, a lot of these people will endorse that NSAIDs do help their pain, so it is somewhat confusing. It's much more expansile, though. They do become locally aggressive, whereas osteoid osteomas do not grow, do not create destructive phenomena the way these can, and these tend to be much larger. So again, we talked about that nidus cutoff being 1.5 centimeters. That's sort of arbitrary, but anything bigger than that tends to be an osteoblastoma. Treatment of these is going to be an intralesional excision curettage with high-speed burring, and then an adjunct, phenol, ethanol, gas plasma, cryosurgery, whatever. And again, depending on location, do you need to prophylactically fix it? Do you need to bone graft it? Do you need to put them non-weight bearing? So depending on the patient and the location. End block resection may need to be done if it's an expendable bone and it's very large. So for instance, if this is in the superior pubic ramus and it's destructive, you may be able to just take out the entire superior pubic ramus safely. Likewise, rib, clavicle, fibula, something like that, or if it's a multiply recurrent lesion. On imaging, these can be expansile radiolucent lesions, usually greater than 1.5 to 2 centimeters, usually a less dense surrounding reaction with only a small shell of sclerotic border compared to that very thick fusiform enlargement that you see with osteoid osteoma. However, these can be very aggressive. There's a variant called aggressive osteoblastoma that clinically and radiographically mimics an osteosarcoma. It just has no ability to metastasize. There's a variable amount of central calcification depending on how much matrix production or how far along in the disease process they are. Histologically, very similar to osteoid osteoma with prominent osteoblastic ribbing of the trabeculae again, but the hallmark here is this loose fibrovascular background stroma. You may see giant cells, you may see a secondary aneurysmal bone cyst, you may see plump osteoblasts. So this can be very confusing again with primary aneurysmal bone cyst, telangiectatic osteosarcoma, osteoid osteoma, but this loose fibrovascular stroma and prominent osteoblasts are what give it away. So here's an example of the image right underneath Gazan's angle in the calcaneus. So you see this thin rim of sclerotic bone, radiolucent lesion on CT. You do see a small amount of calcific matrix production in the central portion of this, but the differential is still wide, including chondroid tumors. But then you get a biopsy and you see this. So you see this osteoid production, this dark pink stuff running throughout the lesion, but then in the background you see this loose fibrovascular stroma. So you see these large lumen blood vessels, loose fibrous tissue, very hypocellular compared to the densely packed wall-to-wall ugly looking cells that we see with an osteosarcoma. And again, you see those eosinophilic round cells surrounding the osteoid, indicative of the osteoblasts. So if we go back and take a look at osteoid osteoma, you don't see that loose fibrovascular background. You do see a lot of hemorrhage here. You do see a lot of blood flow, but you don't see the large lumen characteristics, and you don't see that loose fibrous hypocellular tissue either. Then when we go all the way back to telangiectatic osteosarcoma, you see the lace-like osteoid production, high-grade hypercellular spindle cell neoplasm. You do see some blood vessels, but it's this high-grade spindle cell morphology and the excessive osteoid production that give this away. Likewise, other regions will look like this, where you don't even see the osteoid production, but tremendous amounts of pleomorphism present. So now we move on to Myocytosol Pacificans, or heterotopic ossification. This is a reactive pseudotumor process of well-circumscribed proliferation of fibroblast, cartilage, and bone within the soft tissues. It originates from osteoprogenitor stem cells lying dormant within the affected tissues, and then something happens that turns them on and causes them to shunt down the osteoid lineage of cells. Fibrodysplasia ossificans progressiva is a congenital deadly form of this disease, where fibrous tissue, muscle, tendon, and ligament will ossify with any damage and trauma. It's autosomal dominant, it's rapidly progressive due to chromosome 2 aberrations resulting in an ACVR1 gene mutation. This causes endothelial cells within those fibrous tissues to transform into mesenchymal stem cells, which seems to be triggered by trauma. They often have great toe deformities, such as hallux valgus or rigidus, congenital fusions, things like that. So this does seem to be part of an overarching syndrome. Attempts to resect the heterotopic ossification cause even more robust formation, and this is typically fatal by the 2nd to 4th decade once their diaphragm finally ossifies, unfortunately. So the stereotypical HO that's going to present to most orthopedic clinics, usually there's a background history of trauma. They could have had a traumatic brain injury or spinal cord injury. These can range from asymptomatic to very symptomatic. They can mimic DVT, they can mimic infection, they can mimic tumor. So wide variation in how these present, and it depends on the location that they're at. They can have weakness, they can have stiffness, they can have neurovascular compression phenomena, all of those things. One of the screening methods for this is looking at their alkaline phosphatase numbers, and these will typically be elevated early on. However, as this matures and becomes quiescent, then that will normalize. That's one of the things that may help tell you when these have become quiet to when you might want to determine treatment. On imaging, the mineralization will usually begin about 3 weeks post-injury. So early on, what they'll have is some sort of hematoma in this area on an MRI, so no real mineralization yet. However, 3 weeks the mineralization starts, then it starts to develop progressive maturation with a zoning pattern where you have increased peripheral mineralization and a radiolucent center, just like your own bone, where you have a cortex on the outside and you have bone marrow on the inside, same kind of thing. The MRI will show the surrounding edema when it's active, and then it will become quiet when the lesion is no longer active. So here's an example of early on, you get mineralization within the soft tissues. This was a patient that had a direct contact injury to this area. You get this zonation phenomenon with increased sclerosis peripherally as opposed to centrally. You also see that it's relatively mature in production, so it's smooth borders, it's not spiculated, it's not aggressive appearing. Here's an MRI of that same patient where you have the T1 in the upper left that shows bright signal intensity compared to skeletal muscle, which hints that this is a hematoma process or infectious as opposed to tumor. You have mixed bright and low signal intensity on the T2 on the upper right, which again is odd for tumor, and then you have diffuse intralesional uptake in the gadolinium enhanced image on the bottom there that demonstrates that all of the reactive inflammation, edema, everything around here is very active. Treatment, these are usually self-limiting. What you want to start off with is physical therapy to try and maintain strength and range of motion and prevent contracture in the interim. You want to not intervene with these until they're fully mature. So when it starts, unfortunately you have to sit on it for a while. Eventually when it matures, if it's still symptomatic, then you can consider treatment. Treatment is going to be excision. You want it mature. So bone scan negative, alkaline phosphatase normal, X-ray and CT looks like normal mature bone, and no edema on the MRI. You want it to be symptomatic to consider treatment, otherwise you want to leave it alone. And the reason is because it means this patient has the ability to do this. So if you go in and cut it out, the damage of surgery may incite a new one of these to form. So recurrence rates are actually very high. Some studies show that recurrence rates are up to 100% in all of the patients that it's treated. However, not all recurrences are symptomatic. So it still may be worth going after this in someone who's highly symptomatic. You may want to consider about 700 centigrade of radiation prophylactically within a day or two of surgery to prevent reformation of another one of these, or put them on NSAIDs, usually a high dose indomethacin daily for 6 weeks. Timing of presentation also seems to matter. If this is post-traumatic in nature, you want to wait a minimum of 6 months before you assess for maturity because it's almost never mature before that. If this is due to spinal cord injury, which is usually idiopathic, they'll have a spinal cord injury up high and then all of a sudden they'll develop this and severe contracture around their knee or their hip. That takes a full year to mature. If it's post-traumatic brain injury, it takes 18 months. So 6, 12, 18 months for those, and that's when you'll start assessing for maturation. If it is mature, you can discuss removal. Next one is Melaryostosis, which is a hyperostosis of cortical bone and soft tissue in a sclerotomal distribution. So this is not widespread. It's not typically polyostotic with the exception of the same sclerotome. The presentation usually will be extreme pain. They may have functional limitations because of that pain, stiffness and contractures because they don't use the limb normally. There may be a mass effect of this causing compression on adjacent structures, but you can actually get joint ankylosis if it's large enough or grows across the joint. You can get deafness if ossicles are involved, and you can actually get deformed limbs depending on growth disturbance, depending on the size of this or the age of the patient that it shows up in. It tends to be unilateral and monostotic, and imaging will show an asymmetric cortical thickening with this characteristic candle wax dripping appearance. So here's an example of that in the ulna. This is a radius and ulna that actually have two fibroosseous lesions of bone distally there. This is a patient with what's called Buschke-Ollendorff syndrome that has these fibrous lesions, Melaryostosis, a couple of other constellation of symptoms. But if you look at the cortex of the backside of the ulna there, you'll see that sort of candle wax dripping appearance of hyperostosis, increased matrix production. When you get advanced imaging with the CT, you see it's stuck onto the surface. There's no corticomedullary involvement. And when you get the MRI, you can see in this particular patient, there's an adjacent soft tissue fibrous lesion, which is often associated with these, especially desmoid tumors. And you see, again, no corticomedullary involvement, but no real surrounding edema or inflammation or things like that. It's just a painful process that occurs. Histology will show a variable degree of marrow fibrosis with markedly irregular bone with mixed areas of lamellar and woven bone. It's a mixture of osteocartilaginous, fibrovascular, and adipose tissue within the soft tissue masses adjacent to these, such as in that patient that we just saw with the MRI. Treatment is usually physical therapy, pain control as best as possible. If need be, you can send them to interventional pain management for a sympathectomy, and amputation is last resort because usually even if you shave these off, cut them off, the bone still hurts, they'll regenerate another one. These are notoriously very difficult to treat. However, we're now actually seeing resolution of pain and good responses with some of the newer tyrosine kinase inhibitors like sorafenib. So multidisciplinary approach to these, discussing depending on how long the patient's been dealing with it, how bad their pain is, whether considering a trial of low-dose chemotherapy to help with this. So here's that histology, mixed lamellar, woven bone, very dense, very sclerotic, wall-to-wall osteoid formation, but low grade, not a whole lot going on here, pretty hypocellular and mixed eosinophilic, basophilic portions of it with very haphazard sort of bone formation. The next bone-forming quote-unquote tumor is another tumor mimicker. So this is a bone infarct, which is an irregular calcific deposit with a shell-like pattern, or bone within a bone, or smoke within the chimney, is how this is often described when it's seen on imaging. It'll be irregular serpiginous margins with low intensity on T1, high on T2, with marrow fat preservation in the center of the lesion on the MRI that hints that this is not a tumor replacing the marrow. Treatment is observation. You can actually develop secondary osteosarcomas or fibrosarcomas within these, so it does probably warrant some long-term follow-up. However, typically you want to avoid this. It tends to be intramedullary, but if it's juxtacortical or subchondral, then the bone can collapse, and then you may need to consider arthroplasty, basically because of the structural defect of the bone, not necessarily because of this underlying disease process. So here's an example of that in the proximal femur. You have this sclerotic lesion within the bone. It seems to be well circumscribed, yet breaking out of that. So this can have a relatively aggressive appearance. On the advanced CT scan here, you see that serpiginous sclerotic bone, central area of fatty signal on the CT, not a whole lot going on here, no involvement of the endosteum, no aggressive features. Here's the MRI that shows that serpiginous pattern. On the left you have the T1 that shows the preservation of the bone marrow within the central portion of the lesion. On the T2 on the right it shows you that sort of reactive edematous process to this injury and problem right on the periphery of it. The next thing is an enostosis, which is often an incidental finding in adults. It's usually less than 2 centimeters, but not always. Rarely it can be pretty large. Osteopoikilosis, or spotted bone disease, is basically a disease involving multiple of these scattered throughout the skeleton. It can often be in clusters, tends to be metaphyseal and epiphyseal, but really it can kind of show up anywhere. But these are asymptomatic. They don't really grow, they don't really cause pain, they don't cause structural abnormalities to the bone, so the treatment is observation. If there are multiple, you may need to work up other underlying syndromes. So again, we mentioned before the Buschke-Ollendorff syndrome can be associated with these. You can have other things, and it can be confused with diffuse infiltrative bone marrow metastatic disease. So you do have to make sure that that's indeed all you're dealing with here and complete the workup. It's sort of a diagnosis of exclusion. But here's an example of a large enostosis where essentially it matches cortical bone in terms of density and appearance. It has smooth borders indicating that it's very chronic, it's old, it's been there a while, looks just like cortical bone, but it's within the endosteal bone, not a whole lot going on, no real aggressive features. Typically will be a little bit warm on bone scans because there's more osteoblastic activity in cortical bone. So just like in a regular bone scan, the cortices light up a little bit more than the bone marrow. Then you have on the other side osteopoikilosis in that patient. So you see innumerable mini anostoses scattered throughout this visible skeleton. And again, diagnosis of exclusion, you've got to make sure they don't have other underlying issues or related things. An osteoma is a bizarre phenomenon that usually will show up in cortical bone that can be either sessile or pedunculated. So this can mimic an osteochondroma, it can mimic an osteoid osteoma. These usually do have a dull, deep, tooth aching pain that doesn't go away. They can't get rid of it, they can't kind of get into a comfortable spot, and usually there'll be swelling associated with it, either as a result of the bone growth or abnormality or surrounding erythema and edema. Gardner syndrome is an autosomal dominant syndrome that involves multiple osteomas, extra-abdominal desmoid tumors, as well as intra-abdominal desmoid tumors, soft tissue and sebaceous cysts, and colon polyps, which put patients at risk for colon cancer. So they do need to be screened heavily. Imaging involves a heavily ossified surface lesion with well-defined smooth lobulated borders. It can be parosteal or diffuse cortical thickening, which is the conventional. So the parosteal is sort of the pedunculated version, and the cortical thickening or conventional is the sessile version. Treatment usually is observation. You can resect it with a hemicortical resection if they are incredibly symptomatic. If there's multiple, then you need to work up the underlying syndromes. So here's a small example stuck on the skull. It's very densely calcified. It does not involve the intramedullary space, so it does separate this from an osteochondroma. And here's an example in the midshaft of the tibia where you have diffuse fusiform enlargement. Again, you've got to rule out osteoid osteoma, so you get a fine-cut CT scan on these, and you don't see any nidus. And then that's what hints at this is just an osteoma as opposed to an osteoid osteoma. Finally, the last bone-forming tumor mimicker we have is stress fracture. Fatigue fracture occurs in normal bone. Insufficiency fracture occurs in abnormal bone. So, a metatarsal march fracture in military recruits is a common fatigue fracture, which basically is normal bone that fails under abnormal cyclic stress. So, doing too much on it, and finally the bone fails. An insufficiency fracture occurs in pagetic or osteoporotic bone under normal stress. So, an elderly woman with severe osteoporosis that fractures her proximal femur just by taking a step. That's not abnormal stress, that's an abnormal bone. On imaging, the X-ray will range from subtle linear cortical lucency to periosteal reaction to endosteal thickening to robust sunburst or periosteal reaction from hypertrophic non-union. So this can be confused with osteosarcoma very commonly. On MRI, it will have low signal intensity on T1, bright on the T2 with extensive reactive zone of edema and periosteal reaction. The reactive zone will uptake gadolinium. So here's an example on the X-ray where we're pointing to very subtle findings of cortical scalloping as well as increased calcium deposition proximally in the metaphysis on the AP radiograph, as well as a very subtle cortical reaction with lamellar periosteal bone formation in the mid portion of the diaphysis. Then when you get an MRI, you see the low signal intensity on T1, bright on T2 with the visible crack through it, and surrounding edema in the bone and outside of the bone that indicate that this is a stress fracture. Treatment, protected weight bearing plus or minus immobilization, may need to prophylactically fix it, especially in young athletes or in a weight bearing bone, and you need to work up potential endocrine or metabolic or overtraining phenomena if suspicion is raised. So that concludes this presentation, and again my pitch for Pacific Northwest Pride. Here's a shot of the South Salem Hills Vineyard, which is one of the Duck Pond Vineyards, which is one of the wineries from the Dundee Hills region of Oregon, just outside of Portland, which is one of the world famous regions for Pinot Noir.